I'm Luke, and this is Peter, and we are here to share with you our recent audit on the Sheriff's 911 Communication Center. Let's see. I'll start with our key takeaways. First, the Sheriff's Office 911 Communication Center, which we'll call the COM Center in this presentation, made limited use of options for behavioral health response. Second, the COM Center does take steps to support some vulnerable 911 callers. And third, it's relying on mandatory overtime for staff to meet standards for call answer timeliness. So let's start by defining what we're talking about when we say behavioral health. Behavioral health, or BH, as you'll see in the slides sometimes, is an umbrella term covering issues related to mental health, substance use, emotional dysregulation, and social service deficits such as lack of adequate food or shelter. Sometimes behavioral health issues can overlap with police or law enforcement related issues, such as someone having a psychotic episode who's threatening the safety of others. Sometimes a behavioral health related call might not be a law enforcement emergency, such as a person experiencing delusions calling without a clear problem or request. When a person calls 911, one of call receiver's first tasks is determining the type of emergency. The three basic options are fire, medical, or police. But in cases where a caller is reporting a behavioral health crisis, it's not clear what 911 call receivers should do. If the behavioral health concern coincides with a law enforcement related emergency, then 911 can dispatch police to respond. The COM Center response to behavioral health related calls defers decision-making on whether to offer behavioral health resources and which ones to officers rather than 911 call receivers. Call receivers are not encouraged to offer alternative behavioral health options like transferring callers to 988 or 211, which are phone services that can provide mental health counseling and social service referrals. Managers stated that call receivers are not trained to assess behavioral health needs, and officers are more familiar with local resources. For example, Shoreline, which is a contract city for the Sheriff's Office, and 4 neighboring cities are a part of RACER, the Regional Crisis Response Agency, which can send mental health professionals to 911 calls along with officers. A similar co-response program serves Burien and Tukwila. So resources like these are only available in specific areas. The COM Center provides call receivers some information on 988, but does not have a policy or guidance directing call receivers on which calls would be appropriate for transfer and how to offer that resource to callers. This focus on police officers to connect callers with behavioral health resources can result in delays for low priority calls and additional risk for people experiencing behavioral health crises. Leading practices recommend that clinicians serve as first responders whenever possible. In fact, the implementation plan for King County's crisis care levy states that populations experiencing behavioral health inequities are more likely to be placed into involuntary treatment and be victims of police violence. The county aims to reduce these inequities by increasing access to community-based services as alternatives to law enforcement. Police services may not address behavioral health needs because their focus is law enforcement and public safety. While all officers receive training in crisis intervention, they often can't address the root causes of the crises they respond to. In addition, responding to behavioral health calls uses limited officer resources. So what behavioral health alternative responses are available to the 911 Center? Well, 911 call receivers can transfer callers to Crisis Connections, which is a local nonprofit that provides various behavioral health services, both on the phone and in person. The 988 Suicide and Crisis Hotline provides de-escalation and counseling support for people experiencing behavioral health issues, and 211 provides social service referrals like housing, transportation, and employment assistance, even free meal locations, and more. Crisis Connections also dispatches the county's mobile rapid response crisis teams and designated crisis responders who conduct involuntary treatment procedures. So now that we know what's available, how often did 911 call receivers use these services? In order to answer this question, we requested and reviewed audio recordings of calls associated with 153 incidents coded as mental health related. We also got the notes that call receivers dispatchers, and officers recorded in the computer system to document these calls. Well, so what happened? A little less than half, or 46%, resulted in police dispatch. We heard call receivers say that an officer would call instead of respond in person in some cases, and other calls got reviewed by a sergeant who determined that no response was necessary or possible at the time. None of the incidents in our sample were transferred to 988 or crisis connections. But were the calls eligible for behavioral health services? One of the things we listened for was whether we could hear if the call circumstances involved danger, in which case police would have to respond. So a little over 60%, or 94 out of the 153 calls, did not include dangerous conditions such as someone imminently threatening to harm themselves or others, the presence of weapons or narcotics, or other risks. This means that there were quite a few calls in our data set that could have been eligible for referral to behavioral health services. It's important to note that this is not an either-or situation. 911 callers could be transferred to 988 to talk with a behavioral health clinician while waiting for officers to arrive, which in some cases could take hours. But while transferring callers might sound simple, we also heard challenges to using alternative behavioral health options. First, many callers specifically asked for police, even if their issues were not law enforcement emergencies. Second, in the few cases where call receivers offered behavioral health support, some callers declined it. And third, many callers in the sample we reviewed were identified in the computer system notes as frequent callers, which are people familiar to 911 who may have mental health issues and call repeatedly. It was often difficult to understand what kind of help they wanted or needed, so in some cases, call receivers documented the call but did not take additional action. Through actually listening to the audio recordings, we could see how it would take training and guidance for call receivers to get some callers to accept a transfer to a behavioral health specialist. We make recommendations for the Sheriff's Office to work with subject matter experts to develop standard operating procedures and associated training for call receivers to offer behavioral health options. Fortunately, the Sheriff's Office has a new unit specializing in behavioral health crisis response, the Therapeutic Response Unit. The manager is an expert in behavioral health and indicated that she is ready and willing to help the comm center with implementing our recommendations. A relatively new development in the behavioral health landscape is 911 diversion. Crisis Connections 911 diversion program offers enhanced service to call centers, such as training and data sharing, and funding from the Crisis Care Center levy allowed it to run the program on a 24/7 basis. One of the largest 911 call centers in the county, Valleycom or Valley Communications, is successfully using the service, and Norcom, one of the other big ones, and Redmond Police are signing on this year. Diversion programs have also been effective nationally. Houston, Texas reported that their police and fire department saved over $1.5 million by diverting behavioral health related 911 calls. So we recommend that the Sheriff's 911 Communications Center participate in the Crisis Connections 911 diversion program. I'll hand it over to Peter to talk about our other findings.
Thanks, Luke. For the record, Peter Heineccius with the Auditor's Office. I'll first discuss steps the comm center is taking to support vulnerable callers. Research has shown that racism or bias from callers, call receivers, or first responders can affect outcomes, especially when there are also behavioral health concerns involved. Consistent with leading practices, the comm center annually trains its staff on de-escalation, understanding the effects of trauma, and ways to mitigate implicit bias and apply anti-racism. For instance, the comm center trains call receivers to ask fact-based questions to reduce bias and collect accurate information. Another type of issue is when the call receiver needs a language interpreter to understand a 911 caller, which can delay a response. The comm center uses an interpretation service in these cases, but just logging into the service and going through all of the prompts means they can take up to 1 to 2 minutes before the call receiver can actually ask key questions, such as the location of the emergency. That's true even for common languages, such as Spanish. For less common languages, the wait time can be 5 minutes or more. There are a few call receivers who speak languages other than English who expressed frustration that the current policy does not allow them to use their language skills on the job. The sheriff's office told us they hope to negotiate a certification process like the one they have for sheriff's deputies who can use their language skills after passing a proficiency exam and receiving a pay premium. We recommend that the sheriff's office develop and implement a policy and certification process to allow bilingual 911 call receivers to use their language skills on the job. Next, I'm going to talk about staffing and scheduling at the comm center. Comm center is primarily staffed with communication specialists, which are divided into call receivers and radio dispatchers. To oversimplify a bit, the call receivers are responsible for getting all the necessary information from the callers, and the radio dispatchers are responsible for getting that information out to officers and coordinating a response. Comm Center is budgeted to have 69 communication specialists, and they were fully staffed in February of 2020. But since the pandemic started, they've been understaffed. They've been focusing on recruiting and retaining staff, but it is fundamentally difficult to find enough people who are both able and willing to handle this kind of stressful work. Since mid-2023, they've had around 12 vacancies, which means 1 in 6 positions are unfilled. Despite these challenges, the comm center is still meeting national standards for timeliness that require 90% of 911 calls each month to be answered within 15 seconds. When staffing was at its lowest, the comm center was not meeting these standards, shown here by the bars under the line, but after a recruitment drive, the comm center has been able to meet these required standards since the beginning of 2024, shown here by the bars above the line. There are also recommended standards, where 95% of 911 calls each month must be answered within 20 seconds. After several years of falling short of this recommended standard, the comm center was able to regularly meet it in 2025. Comm center is able to meet these standards with all of their vacancies by relying heavily on overtime. We found that in 2024, around 13% of working hours were overtime shifts. This breaks down into 10% voluntary and 3% mandatory overtime, which means that a quarter of all overtime is mandatory. To put that in perspective, that is equivalent to everyone working an hour and a half of overtime on top of their 10-hour shift every single day. Of course, overtime is not distributed that evenly across employees. For mandatory overtime, assignments depend on who is available for that particular shift, seniority, how many hours of voluntary overtime they've worked recently, and also which employees have medical restrictions on how many hours they can work. This all results in some employees having many times more hours of mandatory overtime than others. Since mandatory overtime is unpopular, this can contribute to low morale. When looking at the drivers of mandatory overtime, we found that compensatory time was a major contributor. Under the collective bargaining agreement, when an employee works overtime, they can choose to receive time and a half in comp time rather than pay. When an employee takes this leave, it's usually necessary to then backfill their absence with even more overtime. So as I mentioned, around a quarter of all overtime is mandatory. Our analysis found that 28% of overtime shifts were necessary in order to backfill for employees taking comp time leave. This means that backfilling for comp time was responsible for about a fifth of voluntary overtime and around half of mandatory overtime. Therefore, we recommend that the Sheriff's Office propose modifications to the comp time provisions in the collective bargaining agreement to see if there would be any way to reduce mandatory overtime. Scheduling all of this overtime takes time, and this is compounded by the fact that the comm center lacks a software system that can handle these scheduling tasks. This means supervisors at the comm center use paper, pens, and whiteout to manage and update schedules across 3 shifts of 24/7 operations. Supervisors can spend around half of their day just working on schedules, taking them away from other supervisory duties such as quality assurance. The latest budget provided funds for the Sheriff's Office to replace its existing time and labor software system, but it may take time until the new system is available. In the meantime, we spoke with other units at the Sheriff's Office who have had success scheduling in a 24/7 environment using other types of software. Therefore, we recommend that the Sheriff's Office ensure that the new time and labor system meets the needs of the comm center, And in the meantime, connect the comm center with supervisors from other units to explore other software options. To recap, while the comm center could expand its use of new alternative options for behavioral health calls, it has taken steps to mitigate risks for some vulnerable 911 callers, and it is meeting its timeliness standards by relying on overtime. Our full report is available on our website. That's the end of our presentation.
Thank you.